Okay. Well, good morning, good afternoon, good evening, everyone, wherever you are, spread across the globe. Thank you very much for your interest. Today, we're very fortunate to have Dr. David Dorward, who is a consultant pathologist in Edinburgh, the sunny Edinburgh, north of where I am. So he's got a strong research background, did his PhD in molecular mechanisms, and now works in digital pathology and AI for diagnosing pulmonary lesions. We're very fortunate to have him today. He's going to speak to us on mediastinal pathology, and particularly, he's going to kind of outline, the anatomy of the mediastinum and the implications for surgical management, biopsy, access, and diagnosis. So, without further ado, over to you. Thank you very much, David.
Thanks very much for the introduction. Can you see my screen okay? Is that okay, Richard? Can you see my screen?
Yes.
Yeah, great. Okay, thanks so much. Okay, so thanks very much for the introduction and for the invitation to come and talk at this webinar today. It's a real pleasure to do so. As was introduced, I work in Edinburgh in Scotland and a lead for the thoracic pathology service. I think the mediastinum is one of those things that I always think that when we look at a chest x-ray or we think about it, we tend to kind of essentially ignore. We look at the lungs, we look at the heart, and in the chest x-ray, you forget that everything else in the mediastinum exists. The problem is once you start to open up textbooks about it, actually suddenly it becomes a completely different beast and very bewildering and slightly daunting. So I suppose I've got some aims of what I want to achieve, but also what I don't want to achieve. So what I'd really like to do by the end of this sort of hopefully 45 minutes talk or so is to go through, I suppose, really kind of my approach that I've developed over the last few years as to how I approach mediastinal lesions, and building from that in terms of actually I think it's one of the really most important, particularly within the thorax, of an area that's really important to understand the underlying physiology and anatomy, as well as probably some embryology, in order to understand the pathological entities that we encounter. So while there are some lists, this is not going to be an exhaustive didactic list of conditions in the thorax. I'm not going to go into each individual condition in huge amounts of detail because just of time and constraint, and I think also just from everyone's ability to be able to ingest such, I suppose, just a wall of information. So hopefully it's going to be a practical and applied outcome of how personally I approach mediastinal lesions. And so as I kind of alluded to, I think it's really important that we touch on a variety of different areas. We really need to explore the anatomy and the embryology, the physiology, the clinical presentation. And once you've taken all of those together, actually then we can start to think about how do we take an applied pathological and morphological approach to these entities. So if we start off with a bit of anatomy, when we talk about the mediastinum, what are we actually talking about? And if we get a sample that says mediastinal lesion, is that sufficient information for us to be able to interpret what we see? So anatomically, you can take the mediastinum and segment it up into a variety of different areas. So you take the anterior mediastinum, and I suppose when we think about mediastinal lesions, most of us probably start to think about anterior mediastinal lesions. And I think that from a biopsy perspective, those are the ones that we encounter the most. So it can be called the anterior or the prevascular mediastinum. So that's between the posterior aspect of the sternum and back towards the pericardium. Contained within that, obviously, is the thymus, which, as we hopefully know, is most prominent in children and young adults. It gradually involutes over time, but it never totally disappears. So therefore, a thymic neoplasm, it's always possible to occur at some point in an individual's lifetime. So the thymus is there. There is also fat. And as the thymus involutes, the amount of fat increases as well. So fat increases with age. We've got lymph nodes, and then there's also the internal mammary vessels as well. So those are the normal constituents of the anterior mediastinum. The middle or visceral mediastinum, I thought handily can be summarized as the stuff that moves. So if we think about that, what does that contain? Well, it's the heart, the pericardium, great vessels, trachea and main bronchi, esophagus, lymph nodes. I think that's really important, and we'll come back to that. And then obviously vagus and phrenic nerves as well. So if we think about it's very much contained within and around the pericardial sac. We think of that as sort of the coat hanger, if you like, to hang that off. The third part is the posterior mediastinum, also known as the paravertebral mediastinum, and that's essentially pericardium backwards. So from pericardium all the way back to the vertebral column. And in there, generally think nerve, 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 and some other things, but it's mainly nerves. From a perspective of where we're heading on in this talk, we need to think, yes, there's the thoracic aorta, we've got venous system, thoracic duct, fat, but it is the nervous system really in the posterior mediastinum that we want to consider the most. I think the other thing that sometimes we forget, particularly when we do this compartmentalization of anterior, middle, and posterior, is also we sometimes forget to consider the superior mediastinum. And that's really important for a number of different reasons. Yes, there are the vascular structures, upper aerodigestive structures that we're all fairly comfortable with, neural structures like the vagus nerve and recurrent laryngeal nerve. But it's also important to remember that either you can have upward extension of thymus, but also you can have downward extension of thyroid and other things as well. And it's really important to not forget superior mediastinal component. And I'm sure we'll talk about it later at some point in this process. But actually, you know, the times where you see a diagnostic pitfall, and there was a case that came through our department not that long ago of something that was diagnosed as a primary mediastinal neuroendocrine lesion. Actually, once you went back, looked at the radiology, looked at the morphology again with a sort of slightly alternate or more up-to-date picture of the clinical and radiological context. Actually, this was a medullary thyroid carcinoma of a lesion that was extending down from an enlarging thyroid extending down into the mediastinum. So that sort of thought about things that can extend into the superior mediastinum in particular can be very important to consider. So that's the anatomy as I think is the sort of the most straightforward way to compartmentalize it. But the next bit is that obviously the mediastinum is a midline structure. And so therefore, actually, we need to really consider where things are from an embryological perspective, because that may explain some of the lesions that we encounter. So, excuse me. So the anterior mediastinum, we need to think about where things have migrated. So the thymus migrates from the third pharyngeal pouch down into the mediastinum. But then obviously the germ cells migrate from the yolk sac and then down through the midline and into the gonad. However, there can be germ cell arrest at various points within the midline, and the anterior mediastinum is the most common site for that to occur. It can happen in other places as well, such as retroperitoneal and sacrococcygeal, but it's the anterior mediastinum for the purpose of this talk that we need to think about. So when you're encountering germ cell tumors, primary germ cell tumors of the mediastinum may, without that sort of nod to embryology, feel very counterintuitive, but actually once we think about it in an embryological context, it makes total sense. So migration or failures in migration in the anterior mediastinum can result from thymic lesions in terms of being in a slightly unusual place, but sequestered germ cells and germ cell tumors, that's the really important thing to consider, and we'll come on to that later on. With regards to the middle mediastinum, if we think about the fact that trachea, bronchial tree, and esophagus all arise from a primitive foregut, and that develops by budding and partitioning, it's unsurprising then that it is cysts that are commonly encountered as lesions within the middle mediastinum. And for the purpose of this talk, we're not actually going to explore the cystic or the cysts that arise and can be identified within the mediastinum, partly because they are relatively straightforward, and on the whole, the minutiae is, do we call it one type of benign cyst or another? So we'll leave that for your own reading and exploration. And the other thought is just think about lymphatics and that part. And then posterior, it's obviously all neural crest development. There's not too much in terms of an embryological perspective that's important in terms of aberrations that may arise to neoplasms later on down the line, but it's certainly important just to kind of keep that in the back of your mind. So it really is the anterior mediastinum that is the important part to consider. So we thought about anatomy, we've thought about the embryological perspective, and I think we just need to have a quick reminder, going back to the anterior mediastinum, which is where we're going to focus the majority of this talk on, is actually what about the thymus? What's the function of the thymus, and does that help us understand some of the neoplastic processes that we encounter? So just for a little bit of a recap, going back to medical school and our early preclinical days, what is the role of the thymus? So the thymus obviously is a primary lymphoid organ. It's there for the development of a self-tolerant, mature T cell repertoire. So you have T cells that, hopefully you can see my arrow, immature T cells are synthesized or are made in the bone marrow. They migrate in the circulation into the thymus, and they are then clonally selected and matured, and then they leave the circulation and then go into lymph nodes. So there's really two components to it. So there is the maturation component, but the maturation component occurs in the thymus with regards to antigen presentation. And there's really two components to that. It's important that they can, the immature T cells are going to be selected for ones that are able to recognize self-MHC, but also that they're not, so that they can recognize foreign antigens presented on self-MHC, but they don't react too strongly to self-antigens and hence drive an autoimmunity. And for that, you therefore need to have an organ that not only has the lymphoid component, but it has to have the epithelial component as well. And that's really where as hopefully you'll see where we're going with this, is why understanding that lymphoid epithelial interaction within a normal physiological context and how that then explains some of the thymic pathology that we'll discuss later on in this talk. So why do you need thymic epithelial cells? Well, so they really, I think that there's quite a nice summary of the fact that they create a training environment, they form a structural network, and for, as we've talked about, both positive and negative selection. So you can think about the positive selection happening in cortical thymic epithelial cells. So they express self-MHC. If T cells don't bind to those ones, then they'll undergo apoptosis. And so therefore, you're selecting T cells that are appropriately recognizing self-MHC. However, the medullary thymic epithelial cells are involved in negative selection. So over affinity to self-antigens results in deletion. And so therefore, hopefully you end up in what can be described as a sort of Goldilocks zone of not too, a bit, but not too much in terms of self-awareness or reaction to self-antigens. Why are we going into that? Well, as I'm sure you're all aware, thymic lesions are the hallmark of thymic lesions is the fact that you often have a composite of both a lymphoid and an epithelial component. This isn't some aberration. This is just a disruption of normal architecture. And I think that's really important to keep in mind to understand the pathology that we're seeing. So let's just have a little look at what does a normal thymus look like. If we go back a second, that is a normal thymus on the right-hand side of the screen, but also this is a normal thymus. And why is that? Well, it's as we've described before, the thymus involutes with age. So a pediatric thymus of a child quite commonly look like that. The thymus of an adult, this is an entirely typical appearance. So we obviously have large areas of fat, as you've got fatty replacement of the thymus, and you've got a gradual atrophy of normal thymic tissue. So this is entirely normal thymus. We've got mature fat, we've got some areas of fibrosis, but just sort of scattered adventitial fibrosis, nothing to be entirely concerned about. You can see that actually maybe there's a very small little benign thymic cyst there. That's entirely normal as part of the involution process. And we can go into higher power and we can actually see the constituent components of this. You'll notice that there are darker areas and paler areas. Those correspond to cortical and medullary areas that we can see. And if we look at this in higher power, I'll make these slides available. Some of the images might need to be adapted, but I'll leave all the links. And there's a really excellent link for normal histology on this on the nus.edu website, and this is where these are taken from. And so characteristically, what we see is we see these small little small lymphocytes. They've got a slightly polymorphous appearance. They're not monotonous. And then you see almost a sort of a two separate component of the epithelial component. So we have Hassel's corpuscles, which are these, which I suppose are the sort of fairly textbook component of the thymus that we learn about in medical school. So these have got a very squamoid appearance. They at places will almost appear or can appear keratinizing, and those are part of the medullary cortex. Medullary thymic epithelial cells, and then the cortical thymic epithelial cells are right here. And as you can see here, hopefully on this magnification, they've got a fairly open chromatin pattern. They can have quite conspicuous nucleoli, and they've got a moderate amount of cytoplasm. It's really important in normal thymus to get your eye into spotting these, because actually that can then become really helpful in terms of neoplastic lesions further on down the line. So that's where we're at. The other thing that I've just put in here, just as a reminder for both myself and you when you're thinking about approaching lesions or anterior mediastinal biopsies, is that we're all very comfortable with mature white fat, but it's important to remember that obviously in the mediastinum there can be, in adults, there's still residual brown fat as well. So it's important to remember that you may well see brown fat within a biopsy. That is not abnormal. It's entirely normal constituent within mediastinal tissue. So it's important just to remember the variation in adipocyte appearance within the mediastinum. Okay, so that hopefully gives us a little bit of a sort of background and platform for what we might expect to see in a normal biopsy. What we then need to do is we need to then start to take that and start to, how do we apply that? Are there further baseline bits of information and baseline understanding that may help us guide to getting towards a diagnosis? And I think it's really interesting that actually we could put up a CT scan, for example, with an anterior mediastinal lesion, and each of these four may actually all correspond to the same CT image. So it's really important, while we are obviously, we kind of, as pathologists, we sort of want to make a straight deep dive straight into the histology, actually understanding what the clinical presentation and the demographics of a patient is really important. So just to walk back through a little bit. So typically 40 to 6-year-old, 40 to 60-year-old males, approximately the same as females, slow-growing lesion with some autoimmune symptoms, myasthenia gravis, red cell aplasia. Hopefully we've all got an idea of what that might be. In contrast, a similar sized mediastinal mass may be in a 15 to 35-year-old, vastly more likely to be in a man, rapidly growing, elevated serum markers. Again, hopefully these are ringing some bells as to, okay, this is going to lead us down a particular line. 20 to 40-year-old females more than males, rapidly growing B symptoms, the patient with B symptoms, SVC syndrome, so SVC obstruction is common. Again, hopefully we're starting to say, wait a minute, there are discrete clinical presentations that account for a variety of different lesions. Here we go, 50-year-old aggressive, there's evidence of invasion on imaging, no autoimmune disease. So can we start to classify these in terms of where we're going to end up with a pathological diagnosis? And hopefully I don't think it's too much of a stretch to be able to feel relatively comfortable that these are the things. So I think going back to our medical student days, we're pretty comfortable that myasthenia gravis is associated with thymomas, obviously also with thymic follicular hyperplasia. However, that's less, we won't really touch on that too much for the rest of this talk. Germ cell tumors, obviously much more common in men, rapid growth, and may or may not have elevated serum biomarkers, and we'll discuss that. Lymphomas, obviously, again, a different spectrum of clinical presentation, and a thymic carcinoma, again, we'll touch on that later on. But you can already see that actually by knowing the clinical history, that is going to rapidly guide us as to how we're going to approach the biopsy that we're going to be examining. Okay, so we've talked a lot about the anatomy, but what does that actually mean in real life? Can that help us to begin to triage if we typed in mediastinal lesion into Google, a vast number of lesions? How can we help to stratify? So we think clinical can help us stratify into different components. Can anatomy or radiological approach do that too? And so the answer to that, obviously, in a slightly leading question is that yes is the answer to that. So an anterior mediastinal lesion, like the one that we can see here, this large heterogeneous cystic focally necrotic mass, what are the most likely lesions that we would account there? If we go from what we know from our anatomical discussion and our embryological discussion, we can therefore predict that the most likely lesions are going to be lesions from the thymus, lesions from a lymph node, or a issue that arose during, from an embryological perspective, say, for example, from germ cell, primordial germ cell migration. And so that's exactly what we see. So thymic epithelial tumors, lymphomas, germ cells, thymic hyperplasia, and then, as we talked about from in that previous discussion, so lesions extending down from into the superior mediastinum from neck. So, for example, thyroid and parathyroid lesions. And those can then be split further down. And we're going to come on to these diagnostic entities more in a wee while. But we can sort of see, essentially, if we badge them around, think thymus, lymph node, germ cells, anterior mediastinum. Those are the things that you want to think about first. And as you'll see, these are distinct from, for example, a middle or a posterior mediastinal pathologies. So from the middle mediastinum, if you remember from anatomy, we said those are the structures that move. It's contained or in and around the pericardium. So is it lymph nodes, cystic structures that we've talked about, either bronchogenic or, for example, an esophageal duplication cyst, something that's a vascular lesion, or potentially even a pericardial cyst. We'll come on to some of these where an overlap of some of them, but I think it's just that important bit, isn't it, in terms of from a middle mediastinal perspective, it's the bits that maybe in the sort of that we more commonly encounter in a lung or pulmonary specific context in terms of mediastinal lymph nodes, whether that be a lymphoma, whether that be reactive nodes, or whether that contain metastatic carcinoma. So that's very much in that bag, and we won't really touch on them much further. So nodes, think nodes, cysts, and things connected to an airway or a GI tract, and that's a sort of fairly typical appearance of a bronchogenic cyst on CT scan. So in the posterior mediastinum, essentially, as we said before, think nerve, 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 and then if you're really stuck, think about some other things. So essentially, schwannomas, neurofibromas, malignant peripheral nerve sheath tumors, and here is a CT scan of a schwannoma. So posterior tumors, you're going to think this is neural until proven otherwise, but have to think about some of the things that may be associated. Extramedullary hematopoiesis, very rarely, and go from there. So we'll park those, and we're going to spend the rest of the time really thinking about focusing on the anterior mediastinum. So without wanting to labor the point too much, we're confronted with a biopsy, but before we put it onto the slide, I want to go back again and emphasize the information that I would really strongly recommend that you have to hand before you even put that microscope slide onto your stage to have a look at it. What are the clinical and radiological features? Because if this is a 12-year-old, or so we'll say if this is an 18-year-old lady versus a 67-year-old man, we are already in two different conversations about what the most likely pathologies are in this context. Again, what are the radiological features? So principally, is it anterior, medial, posterior mediastinum? But also, is this a very necrotic lesion? Is this a solid lesion? Is there evidence of calcification? Are there radiological features that may already be leading you down a particular path? Say, for example, in the context of a teratoma and a germ cell tumor, or calcification, again, in a germ cell tumor, or maybe in a thymoma. So we need to think about those features. I think the next thing that's really important, and again, this comes from bitter past experience of either being caught out myself or having seen others caught out, is know what has been sampled, or actually what is thought to have been sampled. Because sometimes it's sent as this is a lymph node, but it takes, and if we approach it as, oh, this is a lymph node, we may see, in quotes, see a lymph node, where actually it's a bit of thymic tissue that's been sampled again. So it's really important to know this is what they think they sampled, but also take a step back and say, well, if it doesn't all hang together, does it actually fit with what they think has been sampled? The next thing I think that's really important to consider is what type of specimen are you looking at? What I've intended to do in the whole of this talk is purely to focus on biopsies, not to focus on resections, because I think that hopefully makes it more applicable to a broader audience than just those who may be working in a thoracic surgical center. So knowing what kind of specimen it is really helpful in terms of, obviously that's relatively straightforward. We can obviously see whether it's a core biopsy or whether it's an FNA, how it's been prepared, but just have a little think, because it may be that you want to think, okay, knowing what I know about this specimen, there's only so far I'm prepared to go in terms of my report on this case, and we'll discuss that later on. But I think that the really important thing to think about that is, will it answer the clinical question? So say, for example, and we quite frequently have this conversation with our clinical colleagues, is where you're asking the question of query low-grade lymphoma, and you have done an EBUS FNA and just put it in formalin and sent it to us. Actually, is that the best modality of investigation in order to answer that question? And I think particularly when you're into in the spectrum of lymphoid neoplasms of the mediastinum, that's something that's really important to do. And sometimes it's really helpful to, I suppose, prospectively engage with your clinical colleagues if they ask you as to what type of specimen is best, just to have a little think if you can fit together some of the clinical and radiological features as to knowing how you're going to want your tissue and how you're going to want it handled in order to be able to get the best information. Okay, so after that,
David and Ava, just to interject, I'm sorry, the screen has gone green at my end. I'm just checking that it's still visible to other people.
It's visible on my end.
Okay, fine. It must be something at my end. We'll carry on then. Thank you.
So I keep on going? Happy? Great. So hopefully your screens are also okay. But yeah, I'll make sure that the slides are circulated afterwards if for any reason there's a problem. So in terms of finally, we'll then get to the morphology. And this is where I think that having a morphology-based approach rather than a diagnosis-based approach hopefully will help you triage and work through your biopsy in a way that will lead you to getting to either a definitive diagnosis or being able to slot your morphological appearances into a more narrow differential diagnosis. But again, want to stress, I really think that has to be done in the context of what you know about the clinical presentation and the radiological appearances of the lesion. And I think, and this is the sort of my mental approach to how I deal with these, is that actually you can subdivide the appearances from a mediastinal biopsy broadly into 6 categories. You can have a small blue cell tumor, an epithelioid tumor, spindle cell tumor, a mixed epithelial and lymphoid tumor, a fibrosis dominant biopsy, a necrosis dominant biopsy, and probably there should be another one, which is a very scrappy and essentially insufficient biopsy as well. And I think it's important to be very clear that if you're into that final category. So what we're just going to do for the remainder of this talk is just to work through what are the common morphological patterns or the diagnoses that correspond to these morphological patterns. Obviously, as you'll see, it doesn't, and you'll all be very comfortable and aware these don't nicely fit into very neat silos, but hopefully gives you a direction of travel. So if we think first of all about small blue cell tumors, what are we going to see at low power? So it's going to be diffuse sheets of cells, often with quite a lot of crush artifact. The things we're going to be thinking about, so coming down to here, is thymoma, seminoma, lymphoma would be the most common things that we're wanting to think about. But the really important question to ask is, yes, we may see a large number of lymphocytes, but are there epithelial cells hiding in the background? So so we need to think, are there epithelial cells? And then we need to think then a little bit further about the lymphocytes. Do we have a polymorphous population? If so, we're thinking in a sort of thymoma, seminoma territory. Is it monomorphic? And then we're thinking much more in a lymphoid neoplasm perspective. So I think we'll just take a little bit for a couple of minutes just to talk about thymomas. So thymomas obviously have a vast and variety of morphological appearances, and we'll discuss that a little bit more, but essentially have a combination of epithelial cells and lymphocytes. It's important to be aware that in a thymoma, the neoplastic population is the epithelial cells. It's not the lymphocytes. The lymphocytes are the bystanders. If we go back to normal thymus physiology that we talked about at the beginning, that makes total sense. If we've got thymic epithelial cells, then essentially there's a slight bit of, if we make it, then they will come. So they will attract the immature T cells to be part of that lesion. The immature T cells themselves will not be the tumor, but are not the neoplastic component, but they are part of the tumor. However, the spectrum and the interaction of the lymphocytes and the epithelial component vary across, depending on, in part because of the biology of the lesions. And that is fundamentally important, because actually the different morphological features and patterns really correspond to outcome. So a type A thymoma, which we'll come into and talk about a little bit more later on, but very spindle cell rich, lymphocyte poor, and AB, where there's a combination of spindle cell and epithelioid cells, have a very good prognosis. A B1 thymoma, which has a high number of lymphocytes relative to the number of epithelial cells, again does pretty well, whereas a B3 thymoma, which is in figure in panel E here, which is epithelial rich, lymphocyte poor, has a much poorer prognosis before you then tip into thymic carcinomas. So it is really important, I think, to understand that it is what we're talking about, because it's easy to think that we're thinking about that a thymic neoplasm has got something to do with the lymphoid population, where from a neoplastic perspective, it doesn't. It is very easy, though, to be tricked about thymomas unless we take a structured approach to how we deal with the morphology. So I'd really encourage you to start off at a low power. I appreciate it can be difficult we'll really talk from a sort of core biopsy perspective, but it's really important to appreciate the architecture. If you have a lobulated appearance with broad fibrous bands intersecting clusters of lymphocytes with these thick fibrous septae, you need to be thinking thymoma. Perivascular spaces, again, a really nice clue that you have that's the territory that you're dealing with, and as we've talked about, that mixed epithelioid lymphoid population. And where you're in the B1 thymoma territory, where it's very lymphocyte predominant, it's really important to spend time just making sure that you're happy, before you exclude thymoma morphologically, that you're happy that there is no background epithelioid population lurking among those the T cells. Higher power, as we've said, you want to look for the epithelial population, and you want to understand the nature of the T cell population. So as we've talked about, immature T cells are the nature of the beast. And so if you have access to immunohistochemistry, if you had significant constraints as to what you had, if I had one immunostain for a thymic lesion that I was uncertain about, I would do a cytokeratin or a P40, depending on what you have. Those will show up the thymic epithelial cells, and then you can say, therefore, I'm comfortable, I have got a mixed lymphoid epithelial lesion, and therefore this is most likely to be a thymoma. If you have access to TDT, then that's obviously incredibly helpful, because that can then prove that this is also an immature T cell population, and that will help you get into the context of a thymoma. So we've kind of touched on quite a lot of this, but if we go back to our sort of trying to stratify based on morphology, the blue thymomas are those lymphocyte-rich ones, and those are in the category of B1 to B3. So trying to work out the exact, what you call a B1 versus a B2 versus a B3 can be pretty tricky, and the intra-observer variability on the sort of overlap cases can be quite hard. So essentially B1 has a lot of lymphocytes, it's very blue, easily confused with lymphoma. As we've said, you've got to look for those background lurking epithelial cells. So for example, in panel C here, and TDT, I think this is a CD20, and then virtual, there'll be a few cells, and then TDT, there's a large number of immature T cells. So B2, it's still lymphocyte rich, but now it's much easier to see the epithelial cells. I always think if you can see the epithelial cells comfortably in a thymic lesion, I call it B2. People talk about aggregate, and the WHO Blue Book talks about aggregates of 5 cells. But essentially, if you can see the epithelial cells easily, but there's still lots of lymphocytes, it's B2. And then B3, if you struggle to remember it, I would remember it as B3 rhymes with free, and it's free of lymphocytes. So you've got a bit of epithelial atypia, there's very few lymphocytes, and you may in some cases be starting to think about, could this be a thymic carcinoma? And that's how I approach thymomas from that perspective. So in the interest of time, we're just going to skip on to then talk a little bit more about the other things that can present as small blue cell tumors. Again, if we think about, our clinical presentations of thymoma, that might be a 50-year-old woman who has had imaging for some reason and has picked up an incidental mass, or maybe presented with myasthenia. The presentation of a seminoma in germ cell tumors is often very, very different. So in the context of a seminoma, morphologically, you'll see sheets and nests of large cells, prominent nucleoli, clear watery cytoplasm, lots of lymphocytes. You need to worry about lymphoma, particularly when there's crush artifact. Immuno is going to help in this context. But if you've got a young man, maybe with a slightly elevated beta HCG, then that's what you're going to be wanting to think about from that perspective. The other thing you also want to make sure is that you don't fall into the trap of saying, well, this must be a primary mediastinal germ cell tumor. And it's really important to ensure that you advise your clinical colleagues to examine the testes of anybody who you're going to be considering, any man who you're going to consider diagnosing a primary mediastinal germ cell tumor, because metastatic spread from the testes happens not infrequently. But as we all know, germ cell tumors are not just seminoma, but obviously there's a vast variety of others, the morphology of which I'm not going to dwell on too much, but it's important to remember that there is a whole spectrum that ranges from purely a mature teratoma, which we have seen a few of over the last few years in Edinburgh, and a range of others, choriocarcinoma, yolk sac tumor, embryonal carcinoma, to name a few. Immuno is the same as it would be in immunoprofiles are the same as they are in testicular or in ovarian tumors. And so we won't dwell on those, but those can be certainly very helpful. That context of teratoma is always one that is challenging, and obviously if you've got a mature teratoma, make sure that you've examined the lesion in it very thoroughly to make sure that there's no immature components, or that you've got somatic malignancy arising within those teratomas. Obviously, the other component we've talked about in terms of small blue tumors is lymphomas, and I'm very conscious of the fact with Richard on the call, he is by far the expert on this rather than me. So from a non-specialist perspective, I'll give you my perspective on lymphomas in this territory. If we think back to what we know about the thymus, and we know about the lymphocytes or lymph nodes that are there, that can then help us predict what lymphomas are going to be arising. So it's either going to be T lymphoblastic lymphoma in the context of particularly young men presenting with a large bulky mass, small to medium blue cells, high mitotic rate, and we're interested in those TDT positive, CD3, CD7, often CD99 positive cells. It's really important to have ensured that there is a cytokeratin in here as well, so that either that you don't misdiagnose a thymoma as lymphoblastic lymphoma, but also the other way around as well. And I've seen one case of somebody who was diagnosed with a thymoma on the basis of TDT positive expression, hadn't done a cytokeratin, but had reported it as a thymoma, whereas actually it was lymphoma. And the treatment options are obviously vastly different in those contexts. So it's really important to be aware of that differential. In contrast to that, you have primary mediastinal large B-cell lymphoma, typically in younger women, often presenting with SVC obstruction. These have a bit more of a mixed pattern. They can look quite epithelial, often with a lot of fibrosis. And here we're looking for sort of larger atypical B cells, and with the immunoprofile that you can see there. Other lymphomas that you want to think about in this context would be gray zone lymphomas. And also there are other rarer or secondary non-Hodgkin's lymphomas that are extending from elsewhere and then involving the mediastinum. So that's a whiz through small blue cell tumours. What happens if we then see a tumour that has a much more epithelioid appearance? I think the differential here is again important to keep a broad perspective on. It could be thymoma or thymic carcinoma. We'll discuss that a little bit further. Germ cell tumours, as we've discussed already. Lymphomas, as we've discussed already. But now we're starting to think about other epithelioid type malignancies in this territory. And it's important to remember Hodgkin's lymphoma is a not infrequent presentation within the mediastinum. Metastatic carcinoma, also very important to mention, considering just exactly where it is, that mesothelioma may merit consideration. And then finally, it's important to remember that you may encounter, again, from an embryological perspective, ectopic normal tissue. So, for example, thyroid or parathyroid tissue, of which I've seen a couple of cases biopsied as presumed neoplasia, but actually being normal tissue and just ectopic tissue in that territory. So if we then think about those thymic epithelial tumours, we've talked about B3 thymomas, where they can have quite significant epithelial atypia, and sometimes it can be difficult to decide whether you're sitting at B3 or whether you've tipped over into a thymic carcinoma. Thymic carcinoma is essentially for unless you're sort of entering into the world of specialist thoracic pathology, I would suggest that you're aware that squamous cell carcinomas are the most common, by far the most common type of thymic carcinoma of the mediastinum. And then there's a wide variety of much smaller print carcinomas that can occur. I think the really important thing, though, is that if you're getting into the territory of a high-grade epithelioid malignancy that you think is most likely a carcinoma, the most likely thing it is a metastasis from somewhere else to the mediastinum, or its direct invasion from a lung malignancy, or as we mentioned, in terms of a mesothelioma. That is by far the more likely outcome, rather than it being a primary mediastinal or thymic carcinoma. However, they can occur, and it's important to be aware that they do. Sometimes some people talk about the utility of CD5 and CD117 or DOG1 in terms of, c-KIT in terms of help in identifying whether an epithelial lesion of the thymus is a B3 thymoma or thymic carcinoma. In my experience, it's never quite as helpful as you would hope it is, or textbooks seem to suggest that it is, but it's certainly something that may be worth considering if you have that available. Spindle cell tumours, again, I think really helpful to recognise as a separate entity, because then what we're looking at is fascicles, styrofoam spindle cells. And in this context, if you see a spindle cell tumour in the anterior mediastinum, it's a type A thymoma unless you can prove otherwise, essentially is the sort of rule of thumb. Obviously, you can never say never, but the vast majority of these are type A thymomas. The others you can see are here. I suppose the things to flag to you would be, and in terms of, I'll just take one step back. Type of thymoma be relatively bland, relatively monotonous. You won't see that many lymphocytes. They're slightly patternless and slightly haphazard in their dispersal, and a relatively low mitotic count. I would hazard against using a Ki67 in this context, however, because of the fact that you do have a lymphocyte population. Therefore, the Ki67 may artificially elevate what you think may be the proliferative index. So I'd be a little bit careful in that perspective. So it really is morphology. If you think this is bland, I was reading somewhere this morning, putting this together, just about residents typically describing this as a boring lesion, and I think that's probably a fairly good description. If you're in that territory, it's most likely a type A thymoma. Solitary fibrous tumours can rarely occur in the anterior mediastinum, but obviously if you have access to a STAT6, that helps bash that one on the head relatively quickly. And as you can see, there are other lesions there. Nerve sheath tumours I've put in brackets. Obviously, we've talked about the fact that those are most likely posterior mediastinum. They can very occasionally occur in the anterior mediastinum, but also it's that bit of coming back to thinking, where did they biopsy, or where did they think they were biopsying, before you make that call. And if in doubt, and it's slightly unusual, always think metastases to the mediastinum. So we've really talked about type A thymomas. I think just want to go back for 1 second just to think about, we talked about thymomas in general, just that sort of thinking about low power morphology and growth patterns, so well circumscribed, lobulated, thick fibrous bands, that type of thing. And as you can see, we talked about the rest of the morphology in there already. Okay, so as you can kind of see, there's a huge amount of overlap in all of these, but hopefully by starting with the morphology, we can start to narrow down exactly where we're at. So a mixed epithelial and lymphoid lesions, well, you kind of hopefully you're going to say, oh, but David, we've already talked about all of these, and we have, and it's just to slightly trying to emphasize the variety of presentations. So as we've said, sometimes it can be really obvious you're dealing with two populations, sometimes it can be much more subtle, but if you think you've got two populations, you're really going to want to think thymoma, as we talked about. You really want to think seminoma, and Hodgkin's lymphoma is going to be the other thing that you want to look at. So what are the clues to separate those out from an epithelial perspective? If you've got spindle or oval cells that are pretty bland, think thymoma. Large cells, clear cytoplasm and nucleoli, think seminoma. Very occasional large atypical cells, then obviously into sort of Reed-Sternberg cell territory, and you want to think about Hodgkin's lymphoma. From a lymphocyte perspective, again, I think it's helpful to make sure that you've morphologically characterized both of those. So the uniform immature T cells of a thymoma, mixed reactive population of a seminoma, and that polymorphous inflammatory background of Hodgkin's, as well as associated fibrosis, particularly, for example, eosinophils as well, being important to look out for, may give you further clues before you start to reach for your immunohistochemistry request form. And then finally, just to think about, well, what happens if we don't have something that is as relatively straightforward about that? How do we handle a lesion that is mainly full of fibrosis or is mainly necrotic? I think it can be easy sometimes for us in pathology to see fibrosis and to think, they've missed the lesion. But actually, fibrosis in the mediastinum can often be diagnostic and not just the background. You need to think about what you're looking at in terms of, are we seeing broad bands or nodules of fibrosis? So that might give us a clue that actually we've biopsied a broad fibrous band of within a thymoma. It might be that we've got a nodular sclerosing variant of Hodgkin's lymphoma, and so therefore you've got to look really hard to see whether you can see any scattered atypical cells. So for nodular sclerosing Hodgkin's, we're looking for broad collagen bands, a nodular architecture, those lacunar type cells, and obviously the mixed inflammatory background we've discussed already. There is an entity called a sclerosing thymoma, which has a far greater fibrotic component as the conventional thymomas, but normal thymomas, conventional thymomas as well, if they've been unfortunate in the area that they have sampled, may also have that present or appearance on a biopsy. A post-treatment effect may be seen. Primary mediastinal large B-cell lymphoma we talked about previously, and then from a benign inflammatory entity, fibrosing mediastinitis, may also merit consideration. So again, this really comes back down to the fact that yes, detailed morphology is really important. Immunohistochemistry can help for these entities, but actually linking it back to the clinical perspective is fundamentally important. I think it's fair to say we all have a bit of a heart sink when we get a biopsy that's almost entirely or completely necrotic, and it's always difficult to know how to pitch these reports, I think. So what do we do when we see extensive necrosis and hemorrhage? Well, obviously we want to look hard for if there's any viable tumor, but it's also important to have a think about, well, what are the necrotic lesions that we're most likely to encounter? So non-seminomatous germ cell tumors, had a case not that long ago of a young lady who presented with SVC obstruction, and multiple repeated surgical biopsies just yielded necrotic tissue and nothing else. Eventually, she was found to actually have had a mature teratoma that had spontaneously infarcted. But the challenge was, how do we handle and what information do we provide to the clinicians when we're confronted with just necrotic tissue? And I think it's that really important bit about, and we'll talk about it in a second, of not trying to be too helpful and to overcall what we have in the lesion. So the things to think about in terms of necrotic lesions. We've said non-seminomatous germ cell tumours, thymic carcinomas, metastatic carcinomas, treated lymphoma. But I think it's also really, really important to make sure that infection is part of your differential. So could this be actually sampling of a very necrotic lymph node, that this is actually mycobacterial infection, and it may be that this is the first time that infection has been considered. So it's really important to look carefully for histological features that may lead you down, whether that is granulomatous inflammation, whether that's fungal spores, whether that's a requirement that you, if you have nothing else, I would strongly suggest doing special stains for Ziel-Nielsen and a Wade Fight Grocott to look for potential pathogens if required. I'd also say that in terms of handling these, I typically will, if I don't see anything, will cut 2 or 3 levels before I would ever sign a case out that's necrotic, in order to make sure that we're not missing anything on any deeper levels from that perspective. And hopefully you can take from that I strongly feel that necrosis does not equal carcinoma, and be very careful in your wording of your reports if you've just purely got necrosis in your tissue, and because actually how the clinicians handle those reports can massively vary depending on even the slight nuances in your report. I think it's really important, and hopefully you've emphasized this, I think we all want to try and be as helpful as possible. But in this context, if a specimen is insufficient or it's crushed and there's a lymphoid population that you cannot characterize confidently or properly, I think it's really important to say how far you can go with a specimen, and to say there is a small lymphoid population or lymphoid population of small cells. I do not know what these are. You need another biopsy. I think it's really important to put guardrails in your report when it comes into this territory, because the differentials can be broad. Even in a malignant perspective, the differentials and the downstream treatments can really be wildly different. And so the threshold to rebiopsy, although maybe clinically challenging or for a variety of other reasons challenging, I think it's really important to be comfortable and to be happy and not overstretch yourselves in terms of where you put your diagnosis. And so I suppose that take-home message is small blue cells doesn't mean lymphoma. Epithelioids doesn't mean epithelial spindle cells. Definitely don't mean sarcomas, probably a type A thymoma. Fibrosis, it could well be part of the lesion rather than just a reactive process within the mediastinum. And as we've just talked about just now, necrosis does not mean carcinoma. So hopefully that's, I think that's my time nearly up. Hopefully this has given you a bit of a flavor. As I've said before, my aim was not to give you an exhaustive list, but hopefully to provide you with an architecture and a context of how to comfortably or begin to slightly feel less daunted by dealing with mediastinal lesions. Important to think about the anatomy, embryology, physiology. That clinical presentation I cannot emphasize enough. And then hopefully by using a morphology rather than a lesion or diagnosis-based approach, will start to help you to guide in the right direction of what I think is a really fascinating but can be quite a challenging area of pathology. And so with that, thank you very much. This is actually probably is not far the weather in Edinburgh today, but it's a rare thing for that to be the case in January. But any questions, very happy to take them. Thank you very much.
Thank you very much, David. That was really, really good. Just thinking, anyone got a difficult mediastinum lesion, it's worth just reviewing this lecture before you tackle it, because probably save you a lot of time trawling through the books. I think really important points at the end about fibrosis, necrosis, large cells and small cells falling into traps of either disregarding them or overcorning them. So thank you very much. Are there any questions from the audience in the chat, please, for Dr. Dorward? We're getting good comments. Everyone said great talk. Thank you very much. So I don't know, David, if you're able to send us the slides, and we can and Ava is able to, if you email the PowerPoint to Ava, she'll be able to send them on to the delegates, because the way they go into the webinar, we can send material out to them. Would that be okay?
Yeah, totally fine.
Yeah. And if it's a large file, I'm sure Ava can assist with a Google Drop or something like that.
Yeah, I might need to. I did some high-speed copying and pasting of some probably copyrighted images, so I might just need to tweak a few things there. But
I understand.
I might clean out some of the images, but all the text totally fine.
Yeah. So any questions? So I guess from a lymphoma point of view, how many times, what percentage really of how common is lymphoma diagnostically in the mediastinum for yourself? I mean, we see it from all kinds of sites, but I guess mediastinum isn't a common area that's biopsied for lymphoma. But is it something that can be confusing because it can be frequent, or is it not actually frequent in your practice?
So I think it's one of those things, isn't it? It's difficult. We obviously are in a tertiary centre, so we get a slightly skewed perspective. But in terms of, you take a proportion of the cases, the mediastinal biopsies that come to us, I would say that comfortably 10% of those mediastinal biopsies would be lymphoma, or we will redirect to my heme-path colleagues. And I think that particularly Hodgkin's, I would say Hodgkin's, and then we've had a sort of a smattering of primary B-cell and primary mediastinal large B-cell lymphomas that have come through as well. I think, but it's interesting that we had a poster at PathSoc in the summer of cases of metastatic thymoma, and that's the really interesting one. So biopsies of thymomas that had metastasized to other places and then either been diagnosed or unfortunately misdiagnosed as lymphomas in other sites, which I think is the morphology head scratcher, that when you look at them all, once you know the answer, it's clear to see, but it's pretty difficult going the other way around.
Yeah. So odd lymphomas always think query thymoma.
Yeah. This was, I mean, the index case of this was a liver biopsy.
Wow.
And only once when you did a cytokeratin, the whole thing just lit up. And so you had TDT positive cells and it lit up. So it's the metastatic epithelial component that's causing the problem rather than the lymphocytes.
And when thymoma metastasizes like that, is it different elements that are more likely to move than another, or just in that case?
No, so any thymoma can metastasize. Once you've got a thymoma met, you don't do the B1, B2, B3 classification.
Okay.
The probability of metastasis is much higher at B3 than it is at B1, but it can happen. There's a patient who has got essentially a sort of B1, B2 thymoma that has been around since, I want to say, like 2010, 2012, something like that. And every so often he just comes in and gets another of his metastatic deposits chopped out. And I think he's had about 4 or 5 deposits of essentially what looks like B1, B2 thymoma.
Okay. Are there any questions from the audio? Oh, so Michael says, how do you classify thymoma mets? Yeah, you've just answered that.
So you don't. You just once if you've got a recurrent thymoma, either local recurrence post either surgery or radiotherapy, or a metastasis, don't classify it. You just describe it. And I would also be wary of actually classifying a thymoma on a biopsy. I would typically just say that, on a biopsy, I would say that the predominant features are this is a lymphocyte rich, or this is I would defer definitive classification of a thymoma to any future resection specimen.
And what's your experience with sequencing of thymomas?
None. We just don't. It's only sort of useful from a research perspective. It's not got any clinical relevance at the moment, certainly in UK practice.
Okay. And what about, I mean, obviously, things in the mediastinum, they're either FNAs or needle cores. You don't really get excisions. What is your experience, if any, between those different, sampling modalities?
So I get quite grumpy if people send me an FNA.
Okay.
Because it's an absolute nightmare. Particularly if the question is, I would tend to just ask for a core biopsy every time.
Okay. And these days, radiologically, that's perfectly, possible.
Yeah, totally. Yeah. Particularly, we've got one radiologist in particular who's very keen on ultrasound guided biopsy, and actually most of the time they're totally fine.
Okay. Are there any other questions from the audience? No. Well, if not, I'll close the session then. Just thank you so much, David, for an excellent talk. I certainly learned a lot. I don't really deal with the mediastinum, but I do in autopsy practice. So it's always good to be reminded that it's a really complex area that people generally pass by until they have to look at it. And thank you very much to everyone for their attention, for the questions from Michael in particular, and to Ava for supporting, and Diagnexia for supporting the session. Next week, it's back to Hempath for a week. I will be going through some lymphomas online. And then we're having a break because it's the Pathological Society Winter School. I know some people in Kenya and Zambia are able to attend because that's where this teaching program arose from. And of course, so we'll be just having a 2-week break, and then we'll recommence later in February. But I will be here next week, so please join next week. Ava will send out the communications as usual. So at the same time and same place in any of your territories next week, Wednesday. So I look forward to seeing you soon. And thank you very much, David. And I hope the weather continues to shine.
Thank you very much.
Edinburgh. Thank you.
Thanks.